Ladies and gentlemen, boys and girls, welcome to the Indian Journal of Anesthesia podcast. I am Murali here, your host for this episode, and I have Dr. Rakesh Garg, the editor-in-chief of Indian Journal of Anesthesia, along with me for this episode. This is our landmark 50th episode, and I'm extremely delighted that we have Dr. Patrick Giam, who has joined us for this episode. He is the president-elect of the American Society of Anesthesiologists, a practicing neuroanesthesiologist at the Houston Methodist, and a faculty at the Weill Cornell Medical College, the Houston Methodist Academic Institute, and Texas A&M School of Medicine. He graduated from the Baylor College of Medicine and later went on to train at the Texas Heart Institute, and later has been leading the American Society of Anesthesiologists national agenda, and he has been shaping how anesthesiologists train, staff, and deliver anesthesia care in the US. He has steered ASA through pivotal roles, from the first vice president to Speaker of the House, while championing patient safety, team-based care, and innovation. In this episode, we are diving into the future of anesthesia. We are going to look at where we are heading with regards to training, workforce planning, the effect of artificial intelligence on the future of our specialty, the role of anesthesiologists in perioperative medicine, and the global surgery gap that we need to address. Dr. Giam, it's indeed our pleasure to have you on our podcast series. Thank you for joining us. Welcome to the episode.
Thank you, gentlemen. It is my honor to be here with you today, and we hope to give your readers some good information about anesthesiology internationally and in the United States.
Thanks a lot. Dr. Giam, let's start the conversation with something very close to your heart, that is training the next generation. You've been in practice for over close to 4 decades now. So looking into the future, how do you think anesthesia residency training will look in 10 years compared to how it was when you trained?
Well, I think there'll be a lot of differences. One of the things that we're seeing now is that we have very, very highly qualified and very motivated trainees. And this is due in the United States to the extreme selectivity in the application and selection process. We have an imbalance of supply and demand, so there is excellent demand for anesthesiologists, but the supply has been quite limited during the past few years and predicted to be in the next few years. So this means that only the most highly qualified and motivated trainees are being selected. As far as the education itself, I see that in the future, we are increasing the number of residency programs, but these are not just traditional academic residencies. We're also seeing some residencies arise in private practices, many of them large private practices. And in the future, I could also anticipate perhaps some partnerships in residencies between academic departments and even community hospitals. Currently, fellowships are less popular than they were in years past. And part of the reason for that is because the job market is so good and salaries are solid that a lot of residents are electing to bypass doing the fellowships so they can immediately enter the hot job market. So fellowships, while currently a little bit out of popularity, may well swing back toward popularity in the years to come. Because, of course, there's a lot of benefit to patients and to the practitioners to do the more difficult and more challenging and unusual cases frequently associated with fellowship-trained anesthesiologists. Some of the other things that I see in the future is that I think a lot of the didactic lectures, which are currently being done remotely, will continue. That trend will continue. And I think didactics will continue to be done remotely, and the timing will be really at the convenience of the trainee. Simulation also has a big part in the future. I think that simulation will greatly expand in scope and function, likely becoming ubiquitous. ASA currently has its own desktop computer simulator program called SimStat, and that's an excellent program, but I think that simulation will expand greatly in the future, and simulation can help teach future trainees not only basic techniques, but also simulation would give them the opportunity to have exposure to unusual situations, which they might rarely face. And lastly, I think that the training of the future will rely a lot on data, will be data driven, and databases like the Anesthesia Quality Institute, ASA's AQI, will help make what is important for the future to be known in terms of data, not just what we feel might be important. And the data will help drive improvements in what we choose to teach.
Thank you. That's fascinating. You covered a lot of ground there, looking at the supply demand, the importance of didactic lectures, and also the evolving trend when it comes to simulation and artificial intelligence powered training modules, as you mentioned. Can you just elaborate a little bit about the way the future is looking for residents, wherein they might do their first intubation in virtual reality before even touching a real patient?
Yeah, I think virtual reality and AI is just in its infancy in anesthesiology. Has a long way to go to helping us in the future become anesthesiologists. And there's no question that as the AI improves and the resources to use high fidelity AI improve, that I think we're going to see a lot of virtual training, and that can be in technical techniques and also through discussion with interactive scenarios. No question about that.
Dr. Giam, the other topic that you did touch upon when you mentioned about the future is the supply and demand. And this training evolution comes at quite a critical time where globally we are facing workforce shortages. And from your perspective of leading a lot of initiatives for ASA, what creative solutions do you see that might work not just in the US, but in countries like India and elsewhere, where shortage might be even more acute?
That's a big issue. Workforce issues are a big issue for anesthesiologists and for the future of the specialty around the world and in the United States. What we're seeing in the United States is we're seeing a pretty significant imbalance between supply and demand. And in our country, the reason for the decrease in supply is really twofold. One is that the anesthesiologists who were in the baby boomer generation are now reaching the age of retirement and and leaving the workforce. So that's an issue for us as far as that goes. And the other reason is that there are a lot of pressures in the workforce as far as well-being, and so some physicians are choosing to not work a full schedule to help alleviate these difficulties with wellness. And so they're choosing to not work perhaps a full schedule or even retiring on an early basis. So has decreased the supply of anesthesiologists, and the demand has increased because of several reasons. So in the United States, as patients and the population are getting older, of course, a lot of those older patients have a higher need for surgeries. The other thing is that although the increase in the operating room uh, surgeries is increasing, What's really been increasing is the out of operating room or the non-operating room, what we call NORA anesthetics, endoscopies, cath lab, radiology procedures. These have increased dramatically. And so that has really increased the demand for anesthesia personnel. So what can we do to address the supply demand imbalance? So I think the first thing is to try to increase the volume of physician residency training programs. And that's in the works. In the United States, there is legislation which is pending to try to increase the number of sponsored graduate medical education sponsored residency programs. But of course, that requires government funding, which is always tight. So we've also seen a rise in non-government funded residency programs, often done by large anesthesia practices are funding their own residencies or in collaboration with large hospital systems. So increasing the training of physicians is very important. Other things that we're considering to increase the supply is we're looking at innovative ways to potentially utilize internationally trained physicians in the United States. But this is a little bit dependent on a unstable visa situation, and also it has to work its way through the proper credentialing at federal and state levels. But certainly the opportunity to utilize internationally trained physicians in the United States is a possibility. But one thing we have to be careful about when we talk about international physicians in the United States is we don't want to exacerbate any global workforce shortages by necessarily encouraging a lot of physicians to move from where they are needed in their home country to other countries like the United States. As far as other programs, the nurse anesthetists are CRNAs and are anesthesiology assistants. These training programs are also expanding. And so the increase in the expansion of the physician programs, the nurse anesthetists, and the anesthesiologist assistant programs are helping supply, but it will be a while until that reaches full effect. The other issue is we need to decrease attrition. So I've talked a little bit about wellness programs for burnout. The American Society of Anesthesiologists, we initiated a program about a year and a half ago to help with burnout. And it's been rolled out to available to our entire membership. It's a very, very reasonable rate. It's an online program which allows physicians to seek resources not only for themselves, but for their families. And it can be for things like stress-related issues, crisis management, financial issues. All of this is provided at a very reasonable rate. The other things that we want to do to help decrease the attrition rate is to address workplace culture. We need to have good, supportive, collegial atmospheres that we're working so that anesthesiologists, nurse anesthetists, anesthesiologist assistants will want to continue to work in the workplace and where they're working. Also, we have been working on creating some innovative scheduling, which again can help with the culture and with the potential for wellness. And some of those initiatives can include nocturnists, that is, anesthesiologists who choose to work primarily or only during the night shifts. And so they work during the night shifts, and that relieves others who prefer to work during the day of doing those nighttime hours. And those nocturnists working at night, of course, will have their time off during the day or on the weekend. In addition, sometimes there are anesthesiologists who prefer to work weekend only. Again, the same principle as the nocturnist. It takes some of the pressure off of the system for those who prefer not to work weekends, and shifts it to those who prefer to work weekends. We also are working on innovative scheduling so that anesthesiologists who prefer no call or limited call shifts can be well accommodated. I think the last thing is that we want to try to also to affect demand for anesthesiologists. And part of this could be related to the efficiency of the scheduling of the operating room and non-operating room system. So currently, this analysis of the efficiency of the system is done fairly manually. But in the future, it could be that artificial intelligence may assist with helping determine what the optimal use of resources and scheduling is.
Thank you. Uh, I thought that would be a very short and sweet answer, but you have detailed in such a wonderful way the various strategies that anybody anywhere in the world can kind of adapt and use them in their own system. But when it comes to team-based care, anesthetists across the world work, more or less in silos. But there is an ongoing debate about anesthesia care team models where in certain countries, especially like in the US, where there are CRNAs, and of course in some other Scandinavian countries where there are anesthesia assistants, the physician anesthesiologists evolve together with them. What's your thought about that, and how do we evolve with the anesthesia assistants or CRNAs in countries where there are ongoing debates and work together rather than competing?
Well, so the vast majority of anesthesiologists and anesthesiologist assistants and nurse anesthetists, the vast majority in the United States work together cooperatively and collegially every day in an anesthesia care team setting. So that is the vast majority of what's happening. And as anesthesiologists and the American Society of Anesthesiologists, we strongly believe that patient safety should be the highest priority, and that patient safety is best assured when an anesthesiologist is involved in all anesthetics. And so we are happy and we feel that it is the best model for anesthesiologists to work with nurse anesthetists and anesthesiologist assistants in a safe and proven anesthesia care team model, or to have anesthesiologists personally delivering the anesthetic. We think that's the safest for patients, and that's the vast majority of anesthetics done in the United States.
So thank you, Dr. Giam, for wonderful experience information that you are giving to our readership. Let's dive into some amount of some component of tech revolution. You do mention about AR and VR in training. When we come into the clinical practice, probably AI, artificial intelligence, is not just a buzzword. It is actually becoming a clinical companion to us as anesthesiologists and perioperative physician. So when we talk about AI, it has been being used for predicting difficult airway, for ICU care, for predicting many hemodynamics aspect. So as a clinician, which aspect do you think AI integration excites you the most? Prediction, automation, decision support, or something entirely different based on your experience?
Wow, that's a great topic. I think of the many things that we talk about these days in anesthesiology. AI is one of the most exciting. And I think we're just in the infancy of AI. I think we don't totally know where it's going to go, although its potential is tremendous. I liken it to the beginning of what it must have been when electricity first came into being. Uh, I think no one knew what the potential was, and of course, the potential has not been fully realized. I feel it's the same way with AI. It's exciting, and it has a future which I would have difficulty fully predicting. But I'll tell you, in 2025, the things which to me are very exciting about AI. The first is I would view AI currently as being best described as maybe augmented intelligence. So, one thing exciting about AI is its ability to analyze complex, multimodal data streams in real time. And this isn't about replacing us, but it's about enhancing our clinical judgment and flagging patterns which we might otherwise miss, or extracting the key nuggets of information from sometimes quite voluminous and electronic medical record. And these facets, I think, of augmented intelligence will help to ensure that the anesthesiologist is able to comprehend the full clinical picture of the patient and make the best decisions based on just-in-time and real-time information. Another area that I see is that I think that AI has tremendous potential to reduce cognitive burden by streamlining routine administrative tasks like documentation, billing, making summaries, the provision of routine instructions to the patients. I think AI can help us, free us from this kind of clerical work, and so that we can focus more directly on patient care and on clinical decision making, quality improvement. As you know, we're the only medical specialty with true Six Sigma improvement in patient outcomes, and we've always led the way when it comes to the use of technology in improving patient safety. So technologies like augmented intelligence can help our core mission of our profession, which is vigilance, while also helping reduce or mitigate burnout by taking care of a lot of routine tasks.
Just on a lighter note, people do ask that if the AI becomes into our operating room, will anesthesiologists lose their job? But you really definitely, you mentioned it's an augmented support system that we are getting for its inclusion into our system, so that it summarizes the data, it clears up the administrative tussles, and definitely it eases out the work. But I'm sure that, and you will also agree, that probably AI will not kick us out of the operating room. It will remain with us, and we will take it forward in a more improving the quality of the perioperative care of the patients.
Oh, that's definitely the case. So AI, augmented intelligence, will be an advisor, will not be making the decisions by itself, and the patient will not be on autopilot through AI. We're not close. And even if it were possible, we don't think that the best system would be an autonomous AI decision making in the operating room. Not a good idea. What we have is the AI, the augmented intelligence, could be a model for the foreseeable future where the human is in the loop, where the AI suggests and helps define issues for us and helps summarize the large streams of real-time data, which we must understand, but never acts autonomously. The anesthesiologist must always be in the loop and retain final authority, final real-time authority for managing the patient.
Remain secure. I think you are the right person to answer the next aspect also, because in last almost 4 decades of your career, you have seen a lot of innovations, new things which has come into the anesthesia practice. How close do you think we are to having artificial intelligence actually making real-time decisions during surgery? So probably maybe that is keeping you or not keeping you awake at night. It's giving you the right decisions. To what extent we can rely?
Well, I don't think we're that close now. And as I've said, I don't think we should ever get to the point where AI makes the decisions. But I think that AI can augment our native intelligence to help us make better real-time decisions in the future. There are a few things that we should watch for, and one is something called automation bias. So what keeps me up isn't necessarily rogue AI, but it's rather the short or medium-term risks of developing over-reliance on technical tools like AI. And the danger is that if you get an automation bias, is that the clinician may trust a flawed or a biased AI prediction over their own clinical intuition or the real patient, full patient picture. We've seen that where other AI systems have come out in, for instance, the automotive world, where sometimes drivers overestimate the infallibility of self-driving systems. And when they do this, it can have disastrous results. So the anesthesiologist, as being the important, the best trained, professional in the operating room needs to understand the technology and understand that it can be used for important assistance, but it is not the end of decision making. That lies with the human professional, the anesthesiologist, and not the artificial intelligence.
So thank you, Dr. Giam, for exploring on the AI bias about AI's bias that creates. And more recently, even in the IJA, we talked about AI hallucination. So when AI is basically exploring the existing data, and when the data is data remains untrained or it is not authenticated data, these bias are tend to happen. And when we talk today about the tailored-made medicine, the personalized medicine, when you talk about geographical variation in the perioperative outcome, probably those data set which is being explored nowadays, they are being collected. If we use those data set for training the AI models, probably in near future we'll have something robust which can be used as a tailor-made or precision-made AI modeling for better outcome. And you rightly mentioned that those biases are a big concern. We are not in a right state now to allow AI to take decisions in real time. And probably in near future, we can train them better. As we do train our residents, they become better. And at some point of time, we allow them to work independently. We allow them to give anesthesia to us. I think that confidence will take some time once they mature. So moving onwards from the technology to expanding our role, Dr. Murali.
Thank you, Dr. Rakesh. Dr. Giam, you did mention about the increasing role of anesthesiologists outside the OR, about NORA. And earlier this year, when we had a chat with Professor Adrian Gelb, the past president of the WFSA, on our podcast, he did mention that as anesthesiologists, we should be looking at expanding our role outside the OR. So coming to the American Society of Anesthesiologists' vision of this concept of perioperative physician, can you just paint us a picture of what will a typical day look like for an anesthesiologist in 2035, 10 years from now?
Well, I think so. We're going to be expanding our role outside the operating room into the concept of the perioperative physician. So, as a perioperative physician, we have a broader view of the patient and of the patient population. So, we're going to be looking not only at just the operating room, but all of the factors which enter the clinical concerns prior to the patient, well before the patient reaches the operating room, through the operative process, and well into the recovery. So maybe in 2035, anesthesiology groups begin each day looking at dashboards which integrate medical record data, genomics, vital signs, which are being received in continuous input from wearable systems. And then maybe AI helps us identify some of the risks for these surgical populations or for the individual patients. And perhaps teams are, with this information, are better able to design personalized anesthetic pathways for individual patients while also proactively reducing complications on a larger scale. One other thing that we see, other things we see going forward, is we see more team-based perioperative leadership. So the role of anesthesiology groups will evolve perhaps from case-by-case coverage of anesthetics to more system-wide leadership. And a typical day could begin with structured, multidisciplinary groups huddling together, talking about and planning the day, where anesthesiologists are teaming with the surgeons, the nurses, pharmacists, data managers, and together we can align these pathways and optimize the efficiency for the operating room, keeping, of course, a focus on safety in everything that we do. We also want to keep in close contact with the patient's families. And so that can be done in a perioperative setting through networked recovery boards, which monitor all kinds of things, pain, mobility, vital signs, all in real time. And we can use secure video systems to keep families engaged and let them know the status of their loved one and where they are in the process of being able to be released from the hospital. So I think these are a few of the things that could change for us in a perioperative medicine setting in 2035. In ASA, of course, we have come quite far in starting this process. We have created a Center for Perioperative Medicine. We call it CP Med, and we have a couple of dozen contributors to CP Med, collaborators. And these are not only organizations external to ASA, but we also have 6 or 8 industry participants also. So we're getting together all of the people, the anesthesiology groups, the industry, the non-anesthesiology medical groups, also highly involved in our Center for Perioperative Medicine. And we believe that this will be the way that we help lead the specialty into the next phase of perioperative medicine care.
That's a wonderful vision. In fact, I do believe that we are in a very exciting time with so much of changes happening. And this is a big shift from the traditional operating room focused rule that anesthesiologist is used to. But looking at the biggest opportunities that young anesthesiologists can tap into to make the biggest impact outside the operating room, where do you think these opportunities are? Like for the trainees who are listening to it now, we have a large audience for our journal podcast. So can you just highlight a few opportunities here, please?
I think one of the biggest opportunities is leadership. So leadership begins with your department or your anesthesia practice, but it certainly doesn't have to stop there. It can go well beyond there into larger facilities or even healthcare systems. And anesthesiologists need to be very involved in the organized medical societies. And in the United States, we've seen a lot of anesthesiologists becoming involved at the state level, at the federal national level, and at the international level as well. And not just these organized medical societies, but anesthesiologists can be involved in state medical boards across the country. And even we have had several anesthesiologists successfully become elected government officials. One of them is the only anesthesiologist in Congress is Dr. Andy Harris, who is an OB anesthesiologist, is a United States congressman representative out of Maryland. When we get anesthesiologists in these roles, these non-traditional roles outside of the operating room, what we find is that there's a good two-way dialogue. Anesthesiologists learn more about what's happening in the healthcare system and really in the world outside of the operating room, but also these other entities and these other areas learn more about medicine and about anesthesiology too, and how crucial anesthesiology is for the future of medicine. I think it also would be valuable, and there are some U.S. anesthesiologists who are involved in insurance companies and other payer organizations. These things also have much to offer, and anesthesiologists clinically can certainly help the payment systems, the reimbursement systems, which are so critical for us going forward. Another area that I think is helpful is mentoring. So always great to be able to pass information down from one generation to another. And maybe the best way to do that is through an intentional mentoring process. Of course, it's nice to meet and collaborate with colleagues in one's own practice and one's own department. But at ASA, we've taken it even one step further. We have a mentoring program where we have an online process where those who are interested in being mentors or those who are interested in being mentees can fill out a short profile online, and then we match them up. so that mentors and mentees can discuss issues which are relevant to these times. And it's been incredibly popular, especially with young folks. In fact, we currently have over 600 pairs of mentees and mentors. And I think one of the most rewarding things we've discovered is, again, there's an excellent two-way dialogue. While you might think, oh, it's only the senior mentor giving lessons from a career of work to the younger and less experienced mentee, that's not the case at all. What we find is that the senior mentors learn as much from the mentees. We call it reverse mentoring, but the senior mentors learn as much, maybe more, from the junior mentees, and often they learn things like social media, communication in 2025, and so there's just so many opportunities for mentoring to go back and forth. So I think that this is another opportunity that young anesthesiologists could and should get involved in. And I would encourage anesthesiologists who are earlier in their career or in mid or later career to definitely take some business education and business training. These are areas which are not routinely covered in medical training, but so important. If you want to become a leader or become involved outside of the operative setting, you must learn the principles and be able to speak the language of the business of anesthesia. As my friend, Dr. Abalish in Galveston, Texas says, healing is an art, medicine is a science, healthcare is a business. And if you want to be involved in the business of anesthesia and the business of medicine, you must go beyond just the science or the healing.
Well, I think what you spoke for the last few minutes, youngsters should go back, rewind, and listen to it again, because there were so many wonderful points out there, talking from the leadership perspective of how we should train ourselves to the business aspect, and of course the entire thought process of how an anesthesiologist should think more out of the box. That was wonderful. But looking at the way the global geopolitical scenario is, I would say, unraveling. Every day is a new day, and every day a lot of things are happening. There are billions of people across the world who can't access safe surgery and, of course, anesthesia. As the president-elect of the American Society, you've spoken a lot about innovations, a lot of where the future is heading. How can these innovations reach a rural hospital in Africa or a place where there is civil unrest or war happening? Any thoughts on this?
Well, we know that it's a tremendous problem. Only 10 years ago, I think Lancet found that perhaps 5 billion people in the world lacked access to safe surgery and anesthesia. And I can't imagine that situation has improved very much. So innovation is very important, but innovation really only matters if it can reach the bedside. And in this case, we're talking about reaching the bedside in areas which may have limited resources. So while innovation is necessary, we also need to include the term frugal innovation in our focus so that we can try to impact the greatest number of patients across the world. And frugal innovation really refers to a process where we take these innovations, but we design them or scale them in a simple, cost-effective way that don't require a massive amount of resources to deliver the best value that we can under conditions of scarcity, instead of just creating high-end or very resource-intensive processes. So we have to be intentional about designing or creating AI, digital learning, simulation that can run on low bandwidth and low resource infrastructure. And also, we can help local providers to be supported in in the process of adopting these frugal innovation technologies. There's also, I think, a role for large professional societies like ASA, ISA, WFSA. So we should work together, leverage our networks to try to connect the technologies, the frugal innovation technologies and the innovators with the clinicians who need these tools. We should try to use our knowledge, our connections, our platforms to influence those who can help a global shortage and imbalance of clinical care. So perhaps we can influence governments, industry folks, funders, uh, benevolent funders who are looking to provide funding for important global initiatives. And we can try to utilize and mobilize these platforms to prioritize equity in these distributions of new technologies. I think our societies, the opportunity is with our voice, and our voice to the WHO or the United Nations, where health priorities are set. Anesthesiologists can and should lead the way in perioperative care and innovations in patient safety. I think this is the way that we can help fill global surgery gaps. Also, we can focus on training the next generation, training the generation to address global health perspectives, not only in residency and fellowship training, but also ensure that future anesthesiologists see themselves as global citizens and are interested in providing informed, appropriate care to patients in a wide variety of places in the world.
Thank you. Again, as previously you have spoken, you covered a lot of ground there and talking about the importance of organizations coming together, working towards making the innovations accessible to the places where they are much needed. And of course, the academic exchange that can take place between global organizations at a global scale so that innovation, again, improves on a day-to-day basis. Proof is that we are sitting here today talking to you, which wouldn't have been possible 6 or 7 years earlier because the software and technology was not available. The other thing which I would like to ask you is about the impact of anesthesiologists on the global environmental footprint, the carbon footprint, the impact of gases such as desflurane, nitrous oxide, the single-use equipment especially which we use. And there has been a lot of articles, a lot of discussions happening on this front. How do we balance as being, anesthetists being green, at the same time be safe?
Well, safety, of course, is our highest priority. But being safe and being green, not necessarily a trade-off. Being safe, more safe, doesn't mean that you're being less green or vice versa. We have a document which we have created. It's called Greening of the Operating Room. And at its core, it has both concepts, patient safety and being green. And being safe means using clinical judgment to ensure patient safety, but being green, which often means saving resources, reducing costs, being more efficient, these are all certainly possible while being unsafe. So several of the things which we have in our documents are we have a committee on environmental health, which talks about several ASA mitigation strategies to balance the environmental concerns and patient safety. And one is, as you mentioned, it may be valuable to avoid inhaled anesthetics, particularly ones which affect the ozone and which stay in the atmosphere for a long period of time. So we ask anesthesiologists to consider how much inhaled anesthetics they want to use, and also to, when they use these inhaled anesthetics, to minimize fresh gas flow so that hazardous waste would be minimized. The anesthetics which we're focusing currently on include desflurane and nitrous oxide. One recommendation is that institutions may consider removing central nitrous oxide pipelines and instead could substitute portable tanks of nitrous oxide that may be needed on an occasional basis. As far as single use versus disposables, those are sort of local decisions which depend on the available resources and the cost and the priorities. And one thing we do in the United States is we can take what is currently disposable, single-use perioperative equipment like pulse oximeter probes or blood pressure cuffs or compression devices or even some surgical devices like surgical trocars and harmonic scalpels. Many of these single-use items can be safely and appropriately recycled, cleaned, reprocessed, and then used again at a substantial economic discount, and also just saving those resources. So that's a certain a potential good benefit for using disposable equipment by recycling it and causing less harm to the environment. I think anesthesiologists can also be global citizens by thinking about what kind of vehicles they want to purchase, whether those should be petroleum based or electric based. We can certainly think about reducing food waste in hospitals, limiting waste of electricity. Certainly, the operating rooms are a high utilization environment, but can we have systems that automatically reduce the energy expenditure, the lights, the air conditioning when appropriate during extended times when those operating rooms will be down and no cases are scheduled? Each of these actions we take can add up to significant savings for hospitals and facilities and our world environment.
Thank you. That was, in a nutshell, a very nice way of putting together how an anesthesiologist can be a better citizen for the world. Thank you very much. I request Dr. Rakesh, who's our editor-in-chief, to ask you one of the final questions of this podcast. Dr. Rakesh.
Thank you, Murali, and thank you, Dr. Giam, for so many pearls listening to you for the last 48 minutes, and the words of wisdom for us as clinician, academician, as an administrator. I think it will be really useful for those who are listening to you today for their future guidance. But finally, I would ask you, I'll take a privilege to ask you, if you have to pick one thing, just one thing, that will fundamentally change how we practice anesthesia by 2035, 10 years from now, what would it be? And also, I would like you to suggest the young resident who are starting today what all they should be prepared for so that they remain successful and contented.
Well, that's a big question. So what one thing could change our practice in 10 years' time? I would say that the thing which has the most potential is the AI, or the augmented intelligence. But as I've outlined, it's important that we don't rely on augmented intelligence as anything more than a supplement or assisting us with making the critical decisions. So I would tell your young viewers out there to hone your critical thinking skills, but prepare to use them in concert with artificial intelligence or augmented intelligence. This, I think, will give you the best opportunity to have the best of both worlds to take care of our patients going forward. What should you prepare for in the world? If I was a young anesthesia resident starting out now, I would get business training. I would prepare to be broadly knowledgeable about healthcare as much as I could, both inside but also outside of the operating room. The healthcare system needs leaders, and what better leaders than physicians who understand the healthcare system, and physicians who would have business training and leadership training would also be able to make impact in those areas where they have not only the clinical skills, but the leadership and the business skills. So important. And also think outside of just the operating room. Think of what opportunities could exist outside of the operating room to really help a broader segment of the system. When we're anesthesiologists, the work we do is extremely important, but often we're taking care of one or two patients at a time. By moving outside of the operating room into these systems, or even as an elected official, or to try to influence governmental systems, by doing this, you have the opportunity to affect many more people and many more patients than you certainly can on a daily basis, or potentially even in a career. So think big, think broadly, train for being outside. That's
Absolutely. We have to think big. And anesthesiologist, as we say that when we say a clinical disease, now we use clinical syndrome. So anesthesiology is not a singularly branch, is probably a conglomeration of many other opportunities which you have very well described. And you rightly mentioned that we have to embrace artificial intelligence into our clinical practice. But simultaneously, as you mentioned in the training session, we have to train our residents, and probably same way we have to train the artificial intelligence also, so that it becomes a true friend to us and we can use it for the betterment of perioperative safety for our patients. Absolutely, I think these words are the words of wisdom coming from a person with a massive experience, massive knowledge, and taking a leadership role, which all of us will be getting advantage in some platform or the other. Thank you so much, and over to Dr. Murali.
Dr. Giam, thank you. Thank you for this masterclass on where anesthesia as a specialty is going and how we as anesthetists can get there safely, sustainably, and of course, together. So, on behalf of the Indian Journal of Anesthesia podcast team, we wish you the very best as you take over the role of the president of the American Society of Anesthesiologists. And once again, thank you for taking time out of your very busy schedule and joining us and sharing your wisdom. Thank you.
Well, thank you so much for inviting me to be with you here today. It's wonderful to share our international insights, and we certainly value the work that the Indian Society of Anesthesiologists is doing, and we look forward to working with you in the future.
Thank you. Thank you very much. And for all our listeners, we will link resources in the show notes of all the references that Dr. Giam was speaking about. And if you found this last 50 minutes valuable, please share the episode with your fellow colleagues and friends and continue the conversation with us at the Indian Journal of Anesthesia podcast. I am Murali here. Until next time, until our next episode, as we always say, stay curious, stay prepared for the future of our specialty. Thank you very much.